Kassim Javaid, who is the clinical lead here with the Royal College of Physicians, and he's going to be talking about secondary fracture prevention in high-risk patients. Thank you.
Thank you very much, and thank you, Linda, and everyone for inviting me yet again. It seems to be getting bigger and bigger every year. Can I just get a hands up? Who here is an FLS practitioner, nurse, allied health professional? Okay, and who here is a medic, a hospital doctor? And who here is a doctor in primary care? I assume everyone else is a policy maker that's going to pay for all of this. Okay, that's good to know. So here are my disclosures. So I'll go through the non-hip fractures and why we need to focus on them, finding them, and then some service implications. So we're all here to prevent as many fractures as we can with the resources we have. It's not a very complicated thing. Rafa made that point from the health economic perspective. But actually unpicking this is really important because it may mean we have to refocus on what we do. So this is a really important graph, and what it shows that if you take people in Iceland who've had a fracture, and then look at them over 10 years, that actually those who fracture again, half of those fractures are happening in the first 2 years. So when you see someone who's had a major fracture, they're going to refracture really fast. And that changes everything we do down the pathway in terms of identification, assessment, and management. So how do we find them? We've already talked to you, you've got to find them. And we've got hips, wrists, shoulders, and spines. Hips are dead easy. They can be Anthony's ward or other wards. You can't really manage a hip fracture outside of a geriatric ward or a orthopedic ward. There's wrists. The wrists are a bit more tricky. They may not come in to a ward. They may be managed in the outpatient setting, a fracture clinic, even a vertebral fracture clinic. Are there any orthopedic surgeons in the room? Okay, that's interesting. So you have to talk to them and say, well, where are you managing these patients? And sometimes you just see A&E. They don't even hit trauma. They might be going home in a collar cuff. The spine fractures are really important to find. They're very predictive of hip fractures, and they are really predictive of fractures happening again very quickly. But they go everywhere. They may not even come into hospital. They imagine primary care, and sometimes they're even diagnosed. A bit of back pain, take some painkillers. And so, as we've developed our story of secondary prevention, we're wondering, how do we close the gap for those patients? Because we know they're really important, but we know they're really hard to find. And we made a very interesting observation, and any trainees can do this. Go to all your hip fractures last year, look at them, how many had CT scans in the last 2 years, and how many of those had a vertebral fracture that no one did anything about. There is another way to do this, and that is to look at the radiology reports and work with the Royal College of Radiologists, building on the amazing document from the ROS, which tells you if you've got a vertebral, is it normal, is it fractured, or is there something else wrong with it? It's very clear what you have to do. So I worked with the Royal College of Radiologists. We ran 2 audits. We looked at thousands of scans across hundreds of hospitals, and we found that the missing report rate was 50%. And it went from 53.9% to 49.6% after our educational input to say to radiologists, please do something sensible about vertebral fractures. So relying on radiologists, and no disrespect to them, to routinely report vertebral fractures and CT scans is not working at the national level. There are hospitals that are doing it, but not at the national level. So there is another way to do this. You could ask your FLS nurse to reread 100,000 CT scans. That would kill them, and they'd probably leave and say, oh, we're doing that. But we have AI. So AI, you probably think, is like light years away. Okay, and what I'm going to try and show you is AI is now a core part of FLSs. And we want AI to be what FLSs do, because you will not find vertebral fractures faster. So the AI looks at 100,000 scans and tells you who's got a problem scan, a clinician then confirms, and if it is a vertebral fracture, it goes into the pathway. And as Rafa has already said, we need to know what the outcomes of this is. So we did this with the ADOPT study. We looked at 3 hospitals, 35,000 scans were sent, and a third of them were flagged, and then a third of those were clinically confirmed. And what you can see is the impact on the FLSDP key performance indicators. So the first bar is KPI 3, which is spine fracture, and the light blue is what we did before the AI, and the dark blue afterwards. So if you put an AI in, you basically triple the number of spine fractures you find. But what you can see in all the other graphs, the blue bar tends to be the darker ones smaller than the light one, which means when you put that many patients into an FLS, the FLS falls apart and destabilizes. They can't see them all, they can't monitor them all. So AI works, but the FLS link doesn't quite make it. So using Rafa's model, we looked at the impact. What would happen if you put the AI in and you had an optimized FLS? What is the return on investment? And this is work we did with Jack's group from Cardiff and other hospitals across the UK. So there's lots of numbers on this, but basically, if you take 2,000 people in your PAC system with a vertebral fracture, you put the AI in with an optimized FLS, you'll prevent 110 fractures over 5 years per 2,000 people. And that's quite a lot. But as you can immediately see, 7 are just from the AI, but 103 was because you had a good FLS. So there's no point just putting the AI in if the FLS doesn't do it. What does that mean in terms of cost saved? What's the value? If you have a look at here, the social care costs are almost 2 million, and they're way bigger than the hospital care costs. And that's because vertebral fractures cause hip fractures, which lead to social care costs. And this really emphasised what we've been doing for a long time. Finding vertebral fracture patients is a really good way to prevent hip fractures and reduce care admissions. Obviously, nothing is free, and you need to see more patients and treat more patients. So if you're going to put this in per 2,000 patients, this is how much you have to spend on the FLS, about £325,000 in 5 years. But because we're going for an optimised FLS, where we're not going to use anti-resorptives routinely, we're going to use anabolics first wherever we can, the medication budget is large, it's 2 million. And you might think, wow, that's a lot of money, I'm not really expecting that. I thought the FLS budget and everything else would be cost neutral. However, because you have prevented so many hip fractures going to a care home, for the first time, we've been able to show, even if you include the medication costs, it's cost saving. So for every 2,000 people in your PAC system, you push them through the AI, you prevent fractures, and you're cost saving. And we haven't seen that before, and Rafa mentioned that's the sweet spot. So by putting that investment in technology and in FLSs, you actually save money and you prevent fractures. Now there were some caveats to that. It's not a walk in the park. You have to have a very good FLS that is actually taking all comers. Some FLSs say, well, she's a bit old, a lot of comorbidities, a bit of cancer, I'm not going to see them. If you start saying, I'm not going to see relatively unwell people, you're going to miss the boat. And it's really important we find recent fractures. The recency of fracture was a very strong driver. But as I've already said, the biggest driver was having an FLS that works. So we asked a very simple question. Why are the FLSs not able to deliver the increase in capacity? Because what I didn't tell you is the NIHR paid each hospital to have a nurse and an administrator, which should have been enough to do the job. So of the FLSs here, put your hands up if you use Excel in any part of your treatment pathway. It's okay, you put your hand up, we do as well. So Excel is a rubbish system for managing patients. It slows everything down. So what we've learned from this study is this has to be an end-to-end solution. If you want to find those vertebral fractures and prevent those hip fractures, you need to have an end-to-end solution. So what does that mean? You have the AI detection that the doctor then confirms, but then you need a complete digital pathway. No more Excel, no more dictation, no more anything. You need to support the nurses, the pharmacists, the practitioners to have a digital system that works for them. So literally all they do is what they're really good at. Speaking to patients on the phone and telling them this is what's wrong with them, informing them of their choices and getting them on treatment. And then the digital system can then auto-template a letter, it can organise their monitoring and semi-automatically upload to the FLSDB. When we set up the FLSDB, we never imagined people would be manually entering data. We said we'd do it for a few years, but everyone used the database. Nobody has. People still spend hours entering FLSDB data, which is clinical data, and that should be a 101. Please just upload your data. So that's only part of the story. As I've already mentioned, these patients are at high imminent fracture risk. Once you've found them, and an AI will put a picture up, and then within 3 seconds, the nurse can say it's a fracture. You will not find a vertebral fracture quicker any other way, trawling trauma clinics or radiology reports. You have to make sure they're rapidly assessed and get the right treatment recommendation. And that's really important. And I think it is, and Anthony and I have been friends for ages, we get on really well, but this is where we disagree. We're very strong that the patients get the right treatment. And we have now, through NICE and through other organisations, NICE has updated, very clear recommendations that if they're at very high fracture risk, anti-resorptives are not good enough. And we now have really good data. Actually, anti-resorptives prevent vertebral fractures quickly. They have no impact on non-vertebral fractures for the first few years. So you have to be really careful that if you are focusing on preventing hip fractures, you have a really good lined up pathway so that when you find those high fracture risk patients, and they could be hips, spines, humerus or wrists, you can give them access to nice approved treatments. And this is where Andy and I, we get on really well. I think, of course, some treatment is better than no treatment. But if we want to reduce hip fractures, we've got to make sure they get the right treatment. And that's super important. And I've done this work with Rafa. We've been working with this is 6 years old, Rafa, since we've done this. It's a long time. We worked with a team at UCB, and we took 1,000 women. We did one of the complicated models that Rafa talks about and is really good at, which I don't quite, the maths is insane. But we did a couple of things. We said, okay, shoulder fracture, older person, T-score's a bit low, let's put in the imminent risk of fracture. So they're going to refracture a lot in the first 2 years. And don't forget, FRAX, its routine, doesn't pick that up. We looked at how long it takes the drug to work, and how long does it take to prevent non-vertebral fractures. Okay? And then you look at how many of those refractures are you going to prevent. I used to spend ages talking about alendronate, stand up, all that stuff. All that time, talking about jaw problems, whatever. And I was wondering, how many refractures would you prevent? And when you do the math, it is awful. So anti-resorptives are not really good at rapidly reducing fractures. Most people you give anti-resorptives to, if they're going to have another fracture, will still have another fracture. And this is why NICE and other organisations have said very clearly, if you have very high fracture risk, and you truly, in your vision, want to reduce non-vertebral fractures, you need to think about anabolic first. And you might think, well, that's too complicated, let's just get it resolved. But if we were in any other specialty, if we were in cancer or cardiovascular disease, we would not hesitate to use the most potent treatment first, if that's what NICE have told us. And that's a real shift in our treatment. And we have to really make sure we align with our FLS vision. Our vision is not to see as many patients. It's not to treat as many patients. It's to reduce as many fractures as we can with the resources we have. And if you have that as your vision, then you can look at your pathway. Essentially, this is my pathway delivering on that vision of maximally reducing the number of fractures. Because it's not the same as seeing as many patients, it's not the same as giving as many patients alendronate or other drugs as possible. It's about really tailoring the treatment to the fracture risk. And we have matured as a society and as a clinical group to actually do that. And maybe we see fewer patients. So in many services we see fewer patients. Now, how can you achieve that? So it's already been mentioned, the FSDB, it's an amazing thing. There are people here who really help us with our advisory group, and thank you so much. It's got the benchmarks, it's got the graphs which show everything going up and going well. But what they've also done is the KPI 7 table, which you may not have heard about. This is your go-to table. This table will show you how many fractures you saw last year by fracture site. So are you missing the pelvises? Are you missing the humeri? It will tell you how many of the patients are you giving anti-resorptives to, which is good. They are a good treatment. But very importantly, how good is your service in picking up those at very high fracture risk so they can get onto anabolics? If this is 0, then you have a problem. You are missing high fracture risk patients, and that is a problem for the health economic modelling. Critically, how much are you doing it within your FLS or referring to a rheumatologist or endocrinologist who's got a 6-month wait and you have no idea what happens afterwards? We want the endocrinologists, the rheumatologists, the bone experts to come into the FLS and ask the FLS, what's your question? And within the FLS pathway, decide who gets which treatment. So the patient never leaves that excellent nurse and practitioner pathway. we do not want a high patient-informed decline rate. If your patients are declining treatment, they don't understand what a hip fracture is, because it doesn't make sense. If you truly knew what a vertebral fracture, shoulder fracture, or hip fracture would do, and the true risks and benefits of treatment, then you shouldn't really be deciding on to have treatment unless there's something very exceptional about your circumstances. So I'd like to thank my team, and especially Cyrus, who's been my mentor for many years, and leave you with those questions to the agenda points I hope to raise. Thank you very much.